Well, it is just presence of dilated, overlapped, well-demarcated arteries that form like a coil shape in the absence of any connection to the veins, whether it is through a network or a direct, like a fistula. So the lack of communication with the vein is the major characteristic. It's just some elongation of the vessels in a parallel way that look like many different things, like dissection or dilatation and prolongation syndrome or development arterial venous malformation. I'll just present the cases rapidly. This is a 42-year-old male, and most of them, they come with unspecific symptoms. So most of them, they come with headache, mild paresthesia unrelated to clinical examination. Like in this case, what we have seen is some dilatation in the supracellular system with signal voids connected to the probably to the PCAM artery. And on the MRA, what we have seen there is devoid of the signal here. We see some defect here because of the flow stagnation and the difference in the signal, that it looks like a filling defect, but it's not a filling defect. So on the angiogram, this is how it looked like, some dilatation of the vessel with looping, but nothing else more than that. And this is another case, a guy presented with migraine-like headache, and he has some dilatation of the vessels here that it shows loops, which was stable on different venous phase, and this is like late arterial phase that shows no connection to any particular vein, and this is his follow-up angiogram, like after 6 months or 12 months. It shows the same thing, just dilated loops that they are stable for even 12 months. So it looked like something peculiar, but it is not. This is another case of 36-year-old male patient. He's normotensive, he's young, no other peculiar disease, no comorbidities, no neurological deficit. And what we see is some density in the prepontine system, anterior to the pons and midbrain. And on the angiogram, you can see the arterial loop, which is focal, and it continues with a normal artery. This is the trick also. It forms a loop, and then it continues as a normal artery, and it keeps its parallelism. And this is the vertebral angiogram. It shows that this is an infantile PCAM. There is some, always we see that with some stenotic segments. Sometimes this might be significant or not. And I'll show a case where we find this significant. This was in a later case that we had to treat. So this we left alone, just neuropathic medication, pain control, and nothing else. And this is the 12 months follow-up. Nothing changed. The same loops, dilated loops, normal arteries distally. The stenosis is still there, which we did not give antiplatelets for that as well. This is another case, and we have seen all these cases in reality after 2020, and we're not sure if this is related to the pandemic that happened or not, because one of the theories of that disease is the viral vasculitis, really. So this is another case of 24-year-old female patient presented with occasional headache, and you can see the elongation of the supraclinoid artery, and this is her 2 years follow-up on the same medication, painkillers and neurotrophic design. This case was a peculiar case. This was in an older lady, 53-year-old. The other cases, they were in young patients, less than 35 years, no comorbidities. And this lady, she had some numbness in her left side, not on the right side. And what you see here is signal void in the supracellular system on the left side. And she has a history of hypertension, which was uncontrolled. The MRI shows this signal void, and this is the CTA, which revealed expansion of the artery, but then there was like a focal aneurysmal dilatation. And this is the 3D angiogram. It shows the same, some narrowing at the takeoff of the infantile PCAM artery, but then elongation and the normal artery distally. But at this, in this case, this was for us not so parallel, and it represents an aneurysm. So it was like a mixed pure arterial malformation now with aneurysm formation. And in this case in particular, we coiled the case because of the rationale below. It's because of the history of hypertension, because of the history that we anticipated this patient, he will have a turbulence in the flow because of the narrowing and because it's an infantile origin. So we thought that this aneurysm is more prone for thrombosis. And this is why we call this by coils and stenting. So pure artificial malformation now, we see them more and more in our practice. We don't know why, but we think it is related to either it should be related to a new incident. The theories for that, are they congenital dysplasia? It could not be just congenital dysplasia, because congenital dysplasias, usually they affect a longer segment of the arteries rather than a smaller segment. And here, usually the disease is very focal, which is different. It might be acquired by infection. Many people, they think it's because of a healing process of recurrent minor dissections. So this could be also another theory. They mostly occur in the internal carotid artery supraclinoid segment or in the P1 segment. Usually most of them, they occur in here. We have to differentiate them from other diseases like the arterial dissection or the dilative arteriopathy or the development vascular anomaly. Well, it's a little bit maybe easier to differentiate and see, especially now we know the criteria if they are young, no comorbidities, with focal dilatation, most probably they are not dissection if they are not associated with hypertension. But we can be sure of that if we do like MRI brain and see the hematoma in the arterial wall. This would tell us, because most of these patients, they did not show any hematoma in their wall. So they are different. This is a typical case of dissection. You lose the parallelism. And with dissection, you should see some sort of stenosis in a spiral way, not in a focal way, like in this case. So usually you see them in a spiral way. This is why they look different than dissection. Are they different than development arterial anomaly? Yes, it seems they are different, because usually development arterial anomalies are associated with dysplasia and with some sort of embryonic dysplasia to the cortex adjacent to them. So this is a typical case of embryonic arterial anomaly, and usually it's associated with dysplasia. Are they different from dilative arteriopathy? Of course they are different, because usually dilated arteriopathy, it occurs in the vertebrobasilar segment or a large segment of the internal carotid artery. The pure arterial malformation, usually it involves the supraclinoid part. The dilative arteriopathy, which we call the dolichoectasia, usually it involves most of the C2, C3 segments. So usually it is different. Loss of parallelism is one of the things in dilative arteriopathy. Usually the pure arterial malformation, they don't lose their parallel wall. So it looks as well, it's different. So we can differentiate between these two cases. This is typical vertebrodolichoectasia, vertebrobasilar. So the optimal therapy for this is relax, wait, and do follow-up only. Most of them, we followed them, and they have good prognosis. Only in one case, we needed to stent. So we advocate that these lesions only use stent in certain circumstances if they are associated with an aneurysm, or if there is a severe stenosis with turbulent flow, or on the follow-up if you notice that there is a growth and expansion of the wall. So more probably at this stage you would think of treating. And there is a couple of papers published recently that state the same thing. So in conclusion, the natural history of patients with pure arterial malformation, usually they are non-specific. You don't find a lot of symptoms, and usually they are benign, and usually they don't heal. We haven't seen cases that they regress. Most of the time, over 2 and 3 years now, follow-up, they keep the same dilatation and the same shape. So it is a distinct thing that's happening, and it's still a debatable topic so far. And thanks.
Thank you very much for bringing up